history, and so you want to give them something, so we end up doing like around 100. It's more like a maintenance level, but so anyways, there are a lot of different ways to choose it, but I kind of like this one. So this is the New England Journal of Medicine in September of 2013. So one of the most recent guideline type of things that I could find about IV fluids. You know, IV fluids, they're one of those things that we use so often that we sort of become comfortable with them, like, you know, it's no big deal. You hang IV fluid, you just do it all the time. So, you know, it's almost like thinking of Tylenol or ibuprofen over the counter. You know, over the counter drugs, oh, those are safe, right? Nobody worries about anything happening with those, except if your patient is taking, you know, 20 of them every day for 10 years, and then they all come in with their bleeding ulcers and their kidney failure and all these things. Well, IV fluid should be, you know, should be thought of in a different way, not just as something we just give to everybody. It's a drug. It does have side effects. It does cause problems and can be very dangerous. It can also be extremely helpful and life-saving, but you know, you want to think about it in the sense that you are given a medication. So in the blue box, there's a whole bunch of stuff on there, but in the blue boxes is what I kind of took away from this is, you know, up there it says fluid should be administered with the same caution as any IV drug. You know, you want to consider the type and the dose and why you're giving it, what the potential for problems is, and even the cost. Like we talked about, those synthetic ones are a lot more expensive. You know, we normally use the normal saline and LR and that kind of thing, or blood products if we need to. And then they suggest identifying the fluid that you're most likely to be losing. So you're suctioning out from an NG tube or something. That's a different kind of fluid than if you've had diarrhea, or if you lost blood, that's going to be different. So, and then you can try to replace the fluid that you're losing. You have to look at all kinds of different things before you decide which type of fluid that you want to use, like the sodium, the osmolarity, their acid-base status, all these different things. So it should take some thinking. It shouldn't just be, you know, okay, everybody gets, you know, this type of fluid and they get it at this rate. That's it. You know, you really should think about it more than that. And so then the fluid requirements change over time. They're talking about there the cumulative dose of resuscitation and maintenance fluids is associated with interstitial edema. So fluid overload can be a dangerous problem, one of those adverse effects of IV fluid. And they say pathologic edema is associated with an adverse outcome. So people who get edema or fluid overload from getting IV fluids in the hospital are more likely to do poorly, or you know, maybe even over time. So, and then the use of hypotonic maintenance fluids is questionable once dehydration has been corrected. That's kind of an interesting statement because, as I was saying, like in medical school I learned this, you know, every kid that's not, you know, eating or even if they are, like they're in the hospital, therefore they need D5, quarter normal saline with 20 a K. Like every single child, you know, at this 4-2-1 rate. But that's not necessarily accurate. And our patients too, you know. If they come in and they don't have a renal insufficiency, or they don't have, you know, low blood pressure, maybe they're here for an infection in their leg or something, and they're eating and drinking, and they come in and it's 9 o'clock at night, well, you know, at home they would not be eating and drinking overnight. So I'm not sure that we need to replace fluid while they're sleeping necessarily. They wouldn't really need that. If you don't think they're dehydrated and things, you know, this can just be causing more problems. So anyways, then the other people that come in with dehydration, you give them your bolus or you give them things, and then they are better and their blood pressure is stable and all. You might not need to give them. Well, you can have them do oral rehydration. You know, have them use their gut, right? Dr. Branch and the surgeon, they love people to use their guts. So
I do.
See? And then they talk about using the isotonic balanced salt solution. That's referring to LR. You know, everything that I was looking through, all the studies and things that I could find, when you're going to give a large volume of fluid, they suggest that LR might be, or something that's more balanced like that, instead of normal saline, might be a better option, because you don't get this hyperchloremic acidosis like you might get in the high chloride, like we talked about with normal saline using that. So even in patients with DKA and things like that, We have used the LR before. We switched it over to LR because their chloride started to creep up. But normal us medicine doctors, we go to normal saline usually right away. But the thinking has changed a bit, and people are looking more at using LR more often. And then considers normal saline would be better, though in somebody, there are indications for that still, and somebody with alkalosis, you may want to use that instead, because it can correct that better. And then at the bottom there, I just put that on there, the safety of hypertonic saline has not been established. I thought that statement was very interesting because we have 3% normal saline around. I don't think we have it here, but that is, that's a hypertonic saline, and people use it, mostly critical care people use it in the ICU for correcting hyponatremia, severe hyponatremia, people with seizures and things like that. But there have not really been a lot of studies on things like that as far as the safety, so something to think about. So dangers of IV fluids, we talked about several of them already. We said, fluid overload being one of them. But so then you can get metabolic abnormalities like the high chloride leading to this acidosis. You can get alkalosis depending on which fluid you're using, if you're doing too much of it. If you don't put in potassium, or if they have another problem with potassium, or if you do put in potassium, they can get high potassium or they can get low potassium. So you have to be watching that stuff very closely. Their blood sugar can go up or down depending on what kind of fluid you're giving, if they're diabetic, what rate you're giving, and how long you use it, that kind of thing. And you can get some cell lysis. What kind of fluid do you guys use when you're giving transfusions?
Normal saline. Just for flushing.
Yeah, there's a reason for that. Because if you were to use something else, the water might rush right out of that and go right into the blood cells, and they would all burst. And so,
Yeah, but I don't think it's been found to be that critical. I mean,
yeah, maybe
if you
not.
flush it
Theoretically,
yeah,
all the fluid might rush into the cells
Yeah,
and
it's like
burst. Yeah.
nobody's like, I've not seen
Yeah,
four
you
of
haven't
them
seen
in
that.
the end if we have
But
to use it.
I'm
but
sure there's probably a
Yeah,
policy written
but,
about
hang a
giving
small
blood
bag of,
transfusion.
normal saline.
Yeah.
It's sort of been, I don't know that there's studies that prove it. It's,
Yeah.
to me, it's been more tradition
Mhm.
than evidence-based, so I don't
But
know.
how often in the surgery is somebody on just D5? Like never.
Never anymore.
And,
That was gonna be one of my questions as you go here.
I would,
How often
just-
on the
just-
floor do you have your older patients on D5 anymore? Is that done? Do you hang
Very rarely.
D5?
Very
Because it
rarely.
used to be, I know when I was in training, D5 was like de rigueur on a lot of patients. You'd take D5 normal saline.
Yeah.
And I just wonder whether that's done anymore.
I think, surgically, perioperatively, if they have diabetes and things like that,
I was
that
talking
might
about
be different.
D5W, not
But-
D5 normal saline.
No, that's different.
And those are two
I don't
different
care.
things. I think dextrose right now, people are saying don't use it unless somebody's hypoglycemic. I think pretty
That's
much
our main
routinely,
indication.
except for newborns, we do not use dextrose in our IVs, almost never.
Yeah, because it's documented poor
Unless you're-
outcomes of
Yeah.
neurologic outcomes if they code.
I've given D5W for a very brief amount of time to correct hypernatremia,
yeah.
to give free water.
Yeah.
But mostly, if I'm giving, dextrose in the fluid, it's because of hypoglycemia. That's the main
Yeah,
reason.
that's acceptable, but it used to be done for maintenance.
Right, right. And like I was saying, that was that, definite one that I learned about pediatrics too. It has to have the D5, have quarter normal, all that good stuff. So, but we do use it for newborns like that. So. Okay, so these are a few cases that we've seen over the last year or so. So there was this 50-year-old Hispanic guy. He came in with sepsis and pneumonia, and he looked sick. He was ill. We didn't have lactic acid at the time, so I don't know what his lactic acid was, but you could tell that he was bad. His blood pressure was kind of hovering low. He had to have been like a 220-pound guy, big guy, and a history of hypertension, but his blood pressure was, barely 90 over 60. So, anyways, I gave him lots of food. He came in on a Friday. I gave him, a 2-liter bolus, and then we started running the fluid at like 200 mLs per hour, right? So, unfortunately though, I didn't write a stop time to that fluid. And he was better by the next day, from my understanding, and there was over the weekend, and just nobody really realized that he was on all this fluid, and so he stayed on it over the weekend. So I came back on Monday morning, and he was having some respiratory distress, and I think he had been kind of working up to that on Sunday as well, and sometime during Sunday night to Monday morning, his fluid was stopped. But I went back and calculated, 200 mLs per hour times 48 hours, that's almost 10 liters. I think it came out to 9,600 mLs, and I was like, ugh, what did we do to that guy? And he ended up getting ARDS, and had to be transferred to the ICU. I don't think they ever ended up intubating him, and he got better fast. He came back here maybe 2 weeks later and was just fine, and was thanking me for all the great care he got, and wanted me to write a little note that said he could go back to work and that kind of thing. And I was like, oh, thank goodness you're okay. I gave him a big hug, and I was like, oh. And so I'm a lot more, I learned from that to be a lot more careful with, okay. To be a lot more careful in, especially if I know I'm not going to be the one the next day. Sometimes we have all these details in our head, like, oh, no problem, I'll take care of it, but it's okay. I've learned to write on Fridays, saline locket 0600 on Saturday. Now I know they're safe. And then if they need more, the next doctor will deliberately, write for more, and that's okay. But I found that from that guy. So anyways, he's doing okay. And so then we had an 80-year-old white female. She came to swing bed. She was post-op from a total pancreatectomy. She had all kinds of different issues going on. She was barely eating anything. She was on like the liquid. She had to have a replacement pancreatic enzyme. Just all kinds of things going on. But when I first saw her, she was so swollen. Her legs were huge. Her belly was so big. She was wearing a pair of pants that she had worn no problem before the surgery. So during the surgery, she had to have lots of fluids, but it was clearly, she was now getting into a little bit of trouble with it. So I put her on an oral Lasix to try to help with that, because it was just, she couldn't hardly even button her pants up at all. And then she was old. She was 80 years old. So eventually the fluid over the weekend and stuff started kind of creeping up towards her lungs, and she got in respiratory distress. Ended up getting IV Lasix and things like that now. So, she improved as far as her breathing. She had some other complications that made her then get transferred. And I'm not sure if she made it through all that or not. But anyways, that was, another one of those fluid overload type of things. And then we've had 20-ish year old people coming in with DKA. We give them lots of fluid, and they do great. This person did great. They get better. They get better quickly. We watch them real close. We check their basic metabolic panel every 4 hours, and they do wonderfully. And so IV fluid is one of the mainstays of treatment for DKA, and it saves them. It saves their life, and they do great. So IV fluid does great things as well. The next one, person, 70-year-old, she came in with sepsis due to pneumonia, and her lactic acid was 2.3. Now, if you remember, lactic acid greater than 4, severe sepsis, should be in an ICU, early goal-directed therapy, all that stuff. Anywhere from 2 to 4 is pretty severe as well and needs to be treated aggressively, but not quite, to the point of getting the ICU and all. And so, we calculated out her weight and gave her a 2-liter bolus over like 30 minutes, and because at first, when I looked at her, she looked extremely ill, and her blood pressure also was very questionable, 85 over 50, and she just looked like she was so pale, and poor perfusion and all that. Gave her 2 liters, and just after the 2 liters, she was like sitting up and smiling and all perky looking, and I was like, wow. Normal saline I gave her.
When somebody has a high lactate, they not get lactated years.
Well, that is one question. If they have lactic acidosis, that you can check a lactate, and if they don't have
supposedly,
sepsis.
You say if it's above 2, it's abnormal. Is that right?
That is right.
So
yes, theoretically, you
very
wouldn't want
rarely
to
use
necessarily give them
a
on.
ringer's like, I just don't.
Yeah.
There's so many other things in there.
Well, wait,
But anyways,
wait,
so then
let me add a little something
sure.
about that. The lactate you give intravenously is
Ringer's
converted to
lactate?
bicarbonate in the liver pretty quickly. So, I haven't kept up with the literature, but I don't think that it causes a significant increase and the lactate that you draw, because it seems to get cleared out pretty quickly.
I think that's true too. They do have it listed, and if you go look at all the guidelines and things like that as